So today I'm going to talk a little bit about how patients with GIST should ideally be managed. And so this is a refresher talk. I think most of you have a good idea how GIST should be treated. But I think there are several of you who are probably very early on in your GIST journey. And so I'll do my best to give you an overview of what we consider to be the standard management for GIST. There are going to be additional talks going over new research in GIST, immunotherapy for GIST, surgical approaches, etc. Okay, so my disclosures. And so GIST means gastrointestinal stromal tumor. The gastrointestinal tract starts all the way from the mouth all the way to the rectum. You can have GIST basically anywhere in the GI tract. The two most common locations, of course, are the stomach and small intestine, but you can even get it in the appendix, and rarely you get in other places like the esophagus and what is called the mesentery, which is like a curtain. If you are suspected of having GIST, if you are incidentally found to have an abdominal mass or bleeding, there's a series of tests and procedures that really need to be done to optimally, treat you. You should have imaging, either an MRI or CT scans of the abdomen and pelvis. Whether you really need to do the chest early on should only be done if you really have any additional symptoms. Should be evaluated by a multidisciplinary team with a surgeon, medical oncologist, some occasions a radiation oncologist, and an expert pathologist who knows how to classify GIST tumors. And then, of course, it is strongly recommended, the National Comprehensive Cancer Network strongly recommends that patients have mutation testing. And as Norman mentioned, that's still one aspect of the initial planning that's really lacking in many cases. And there's a separate section at 11 o'clock that we're going to talk about mutation testing, why you do mutation testing and the implications of that. So at UCLA, this is our sarcoma team, and GIST is a sarcoma, and so we have a large group of people who help take care of patients like yourselves and other sarcomas, and I'm sure some of you know some of the people up there. So just, one way I try to break down this talk is to, when people present, it's either you have a localized lesion, and that is considered a resectable lesion, and I should have put surgeon. I gave this talk a little while ago at UCLA. So Dr. Alvar is our sarcoma surgeon who does all the GIST surgeries at UCLA. And then you have unresectable GIST. Unresectable GIST means it is in multiple locations or it has spread to the liver, etc. Those you can consider radiation therapy. Chemotherapy is really not a consideration. The response rate to chemotherapy is exceedingly low, under 5% or so. And so when you're diagnosed with GIST, the first question people are, what's my prognosis? What should I expect? And so the real question is, okay, so what features of my tumor really lend to giving you an answer here? And so this, you don't have to memorize, I don't memorize this, but this is the result of many, many studies where people looked at some of the key features of GIST and put together this table to give you an idea of what are your chances, to give us an idea to tell you what your tumor is going to behave like. Important things are the size of the tumor, the location, and the number of mitoses. So those are the three cardinal features that we look at when I have a discussion with the patient as to how your GIST will behave. One thing you'll notice is that mutation testing is not on there as yet, and in the mutation talk I'll go through some of that in more detail. So, but at UCLA now, anybody who is diagnosed with a new GIST, we do ask for pathologists to send it off for mutation testing. Usually, the normal place we send things off to is a night center at OHSU. But if you have it done by Foundation Medicine, they do additional sequencing. But at least you should have some sequencing done, and it has several therapeutic implications, particularly up front. GIST, as you know, is a disease of mutation. The two main mutations are in KIT and PDGFR alpha. platelet-derived growth factor receptor alpha, if you wanted to know. And about 80% of the mutations are in KIT, but another about 8 or 9% are in PDGFR. And then they have the so-called old definition of wild type, which we don't really like to use that term anymore, as wild type doesn't really mean GIST. In fact, we found that there are several other mutations that have been found in the patient group, that 10% that previously was considered wild type. And I know there's a whole section on wild type just in the upcoming days. But other mutations have been found in a protein called BRAF. BRAF is a protein within the cell. It's also very important in melanoma. It's actually the same mutation that's seen in melanoma, and there's a drug for that called vemurafenib as well. NF1, neurofibromatosis type 1, so there are some GIST syndromes that are associated with the neurofibromatosis syndrome. And lastly, we found that there's many of the patients who previously were called wild type mutations in what are called the succinate dehydrogenase genes. That's a group of proteins that are important in how your cell generates energy, essentially. And then there's a small percentage that have not been identified, but will be identified in the future. I think Dr. Chmielowski will talk about some of the additional mutations that recently have been seen. I'm going to give a mutation talk later, but I still like to preference and, what is a mutation? What is the implication for saying you have a mutation? So in the cell, proteins do all the work in the cell. They're the little engineers of the cell. Each cell has what's called a cell membrane, which is the outer lining of the cell. And so that's what's called a plasma membrane. And the little torpedo-looking blue things are the receptors. So receptors bind to things called growth factors, which are proteins that are outside the cell. Once it binds, it leads to a cascade within the cell, and other proteins ping-pong off each other and do the work of the cell. So that's the normal way. That actually leads to a process of cell growth and cell division. And now, if you have a mutation on the right panel, you can see the little red mutation that's indicated there. So what the mutation does is it actually turns on that process of ping-ponging within the cell, and you don't actually need the growth factor to bind. So you have something that's like a light switch that's constitutively on. You always have a process that's going on leading to growth. And so essentially, in GIST, if you have mutations within KIT or PDGFR, that leads to a constitutive growth promoting signal. And so that's the idea of a mutation and what the implications of having a mutation are within the cell. And so a few years ago, or I guess maybe 20 years ago now, people started realizing that there were the mutations within the cell are actually amenable to blocking them with drugs. And so Gleevec was originally identified for a disease called leukemia, actually called chronic myelogenous leukemia. And actually the ABL protein actually is very similar to the KIT protein. So some scientists at the Dana-Farber with George Dimitri and Heike Jansu knew about this. And this was the first, or one of the first patients to receive Gleevec. And you can see in the panel A, the upper left panel, this patient had metastatic GIST with a disease in the liver. And panel B is after, I think, about 4 weeks of treatment. And then panel C is 3 or 4 months after treatment. So they even had, they had quite a remarkable response and healing of the liver. So this began the Gleevec era and the era of targeted therapies for GIST. This led to the registrational trial, which actually got the medication approved, and it was about 150 patients and 2 different doses of Gleevec. And people responded phenomenally well. More than half the patients were responding, but overall about 80% of the patients were seeing benefit. Now this is, some of you probably were living at this time and understood what was going on, that you had a disease for which chemotherapy wasn't effective. And frankly, many pathologists could not discern GIST from something called leiomyosarcoma, which is smooth muscle sarcoma. Under a microscope, leiomyosarcoma and GIST look very similar. And so pathologists were not clear exactly how to differentiate them, because leiomyosarcoma can respond really well to chemotherapy, whereas GIST is generally does not respond to chemotherapy. But it was an identification of KIT by Finnish and Japanese groups to mark GIST that allowed people to start to differentiate these diseases and come to a point where you can use medications against them. So this led to the approval of Gleevec, and people were surviving, not only responding, but surviving longer. And then people started to ask more important questions. So, at that time, in the early 2000s, we weren't sure exactly what dose of Gleevec to use for people, because it's quite different to use 400 milligrams versus 600 or 800 milligrams of Gleevec, and it's a battle, especially at the beginning for many people. And so this was a review where it took 1,600 patients, and you can see it's not clear if you just look at it this way who was the right dose of Gleevec. But over time, mutation analysis got better and better, and it became cheaper and cheaper, and more people were doing it. And so they started to stratify and say, okay, well, let's look and see how patients with exon 9 mutation do with the different doses. Let's take a look and see how patients with exon 11 mutation do. In this diagram, you can see here that in all cases, the patients with non-exon 9 mutation respond better, do better compared to the exon 9 mutation. But you can see here, in the light blue line, it's clearly better. Higher is better here. The light blue line, 800 milligrams, is better than 400 milligrams for exon 9 mutation patients. And not only for progression-free survival, it's how long your disease grows before it is called progressive disease by standard criteria. And that's and not only were people going longer before the disease grew, but also you were having a better survival. And then this is a different study, and they looked to see what is the response rate. If you have exon 11, your response rate is somewhere around 70%. If you have exon 9, that's the blue bar, it's about 30%. Wild type is about 20%. And probably the wild type patients that are responding probably have, quote unquote, wild type, probably have PDGFR mutations in this study. So I know I talked a little bit about why chemo is not effective. This was a study where they went back and looked and said, okay, how do patients with Gleevec do compared to patients with GIST who get chemotherapy? And you can see how much of an improvement. An improvement like that is quite substantial to see in oncology. Most of what I've been talking about right now has been talking about patients who present with disease that's not resectable or it's metastatic. And so now I'm gonna, the other question that came up was, well, with people who have just isolated disease, well, should those patients get Gleevec? And the answer is yes, but then the question is how long? Because one, the medication is extremely expensive, and then there's a human cost in terms of side effects to deal with this thing. And some people actually have to come off of it because they can't tolerate the side effects. Other people, eventually their body acclimates to it. I'm sure many of you can tell me much better than I can. So this was a study that was actually only read out in 2012, where they took nearly 400 patients. Half the patients were given the medication for 3 years. This is a patient who had surgery, and then how long should you be on Gleevec? So you got it for 3 years or 1 year. It's a little hard to see. Essentially what it says is the people who get it for 3 years do substantially better. And not only does it take much longer before your disease comes back or grows, but essentially what happens is it also, people live longer. And so because of that, the FDA granted 3 years. But then it goes on and on, right? So well, if it's 3 years, what about 5 years? And so some of this has not been fully read. The 5 years versus 3 years hasn't been read out. And the question is, then it's like, should you be on 7 years or 10 years? And I personally leave patients, especially high-risk patients. Remember I showed you the table of, how do you differentiate who's low risk or high risk? All intermediate and high-risk patients I leave you on for life. And the low-risk patients, we have a discussion. Most low-risk patients, I want to take you off because there are problems with the medication. And so that's how I practice. And Dr. Chmielewski, he'll be here in a little while, but he does that as well, and that's what we generally do in ACO. Some physicians go by the book because it's only set for 3 years. So if you're, that's something you really have to if your oncologist says only 3 years, that's by the book, you really have to ask questions about that. I'm not going to go too much into resistance. I'll talk a little bit about more in the mutation talk, but people can be resistant upfront to Gleevec. It's only about 5% of people, and about 14–15% of people have early resistance, and some people eventually go on to get what are called secondary mutations or acquired resistance. That is, the tumor kind of gets used to the Gleevec, and the tumor wants. Remember, it has a strong survival bent. It wants to live, and so the Gleevec's keeping it down. So sometimes it finds a way to get past the medications, and that's what when you develop secondary mutations. And the secondary mutations, the drug doesn't bind as well to the protein anymore. And so that's one of the cardinal problems that we have for GIST now. This is another complicated slide, but essentially what it shows are kind of a subway map, and it shows that the protein, the KIT protein, I almost have it here. There it is. I found it. So this is the KIT protein. Quite a bit of the protein is actually outside the cell. Some of it is actually in the cell membrane. This part here, where exon 11 is called juxta, next to the membrane, and there's a bunch of it inside the cell. And so what somebody did is actually they lined up all the different types of mutations that are found, and they showed where the primary mutations are, the secondary mutations, not only in KIT but PDGF as well. Okay. What I needed to show you that this is where most exon 11 mutations are in this little area. Most exon 9 mutations are extracellular, and the secondary mutations, particularly 13, 14, 17, and 18, are really inside the cell. Just so that's most of what I'm going to talk about Gleevec. The second generation came just in 2006, 10 years ago now, and because they were already saying that some people had failed Gleevec. So this was the Sutan trial led by Dr. Dimitri. And in this trial, they actually allowed the patients who, you got Sutan or you got placebo, because people didn't know what else to use at that time. And so anybody who went on placebo actually was allowed to cross over to Sutan when your disease grew. And the blue is Sutan, red is placebo, and so clearly the blues were better. And on average, people were getting 27 weeks, so which is almost 7 months of benefit. But compared to the 2 years of benefit on average of Gleevec, that's quite a significant reduction. And so this is one of the themes, is that the benefit of the second and third line drugs is less and less. But so there are outliers and people who do much better than what these averages. Remember, this is aggregated in several people. This is the result. You can see that Sutan is better than placebo, obviously. And then the third line trial is for regorafenib. Stivarga is the trade name. And this was recently approved as people were using sorafenib, and so sorafenib actually looks almost exactly like regorafenib. It's almost the same molecular structure, but for some reason the company never ran the trial to get it approved. So, they made regorafenib, and it works. So, yeah. Okay. Currently, this is the national. When we try to get drugs approved for you, we have to show the insurance something, and this is called the NCCN guidelines, and it has a compendium of drugs that can be used in GIST, and you can see the other things are sorafenib, nilotinib. I'll talk a little bit more about nilotinib later. Dasatinib and pazopanib. There is some data that pazopanib, also known as Votrient, can work in GIST as well, because it does have activity against c-KIT and PDGFR. So those are kind of the main medicines we use for GIST.